Good evening, everyone, and welcome to SWESEM Learning. It's our platform for a practical, high-yield education in emergency medicine. These webinars that we do are designed to bring the frontline case-based teaching to clinicians across Sweden, Europe, and worldwide. And the focusing mainly on the skills and decisions that matters in the ED. My name is Mohammed Ibrahim. I'm emergency physician staff specialist at the University of Uppsala. Together with my fellows, Tobias Olsson and Malin Siebert, gonna moderate the evening's webinar together about back to sinus. I usually start my webinars with cases just to refresh you guys and how gonna you manage these cases in the future. Imagine like you are sitting in your ED in the early morning, and then you see like the nurse coming to you and want you to check about a patient who is 51 years old, complaining of a sudden shortness of breath and a severe palpitation. And when the triage nurse put him on the monitor, actually, it was the pulse shouting about 180, 190 beats per minute. And the blood pressure is about 110 to over 80. And then she come with this nice and sweet ECG paper. And you see like the ECG looks really chaotic, looks really wide complexes and irregular. And she asking you what to do. Will you move the patient to the resus room, or are you going to put him on a monitor and starting to do your actions? This is very important topics to know the irregular wide complexes because you don't know if this is really a polymorph VTAC or this is an atrial fibrillation with a pre-excitation. And what are you going to do? How can you manage this patient? Will you shock him, but he's stable, or are you going to treat him by some medication? And in this way, which medication you are going to use? Because there's some important and dangerous things that you keep in mind and not putting this guy into a VF. So tonight I have the honor to present my one of my mentors in ECG, which is Dr. Hesham Ibrahim. He's an emergency medicine consultant from England, and he is internationally recognized as an ECG educator, the creator of the EPEC courses, if you guys know them, and which is recently have been recognized by the Royal College of Emergency Medicine and the platform From Zero to Hero. He will absolutely guide us through his practical strategies that you can use in your next shift when you work. Thank you very much, guys. Now, Tobias, the scene is yours.
Yeah, sure. And so delighted to have you, Hesham. It's going to be a blast. And just to remind everyone about the structure, you can write your questions in the chat, and Hesham will take us through two cases in the beginning, and then he will answer some questions, and then we will return for a final case, and we will wrap it up with more questions if you have any, and hopefully we will be finished at 7 o'clock, but we'll see how much time Hesham has and how much questions we have. So use the chat for questions, and when you have a patient like Mohammed's in the case, I would just rerun this webinar, and you will have all the answers. So that's the answer. The stage is yours, Hesham.
Thank you so much. It's a great pleasure to be with you guys today. It's my first proper presence with the Swedish Society, and I'm really excited about it. I've been keeping an eye on the work that you guys have been doing for long, and it's an amazing work. So thanks for having me. So I'm just gonna start by sharing my screen, and let's see if that looks like it is. Yeah, okay. So I'm afraid that the cases that I'm going to present today are not going to be as scary as the presentation that Mohammed presented. I've got three other presentations that are following a similar theme, which is managing broad complex tachycardia. So I've got no conflict of interest here. And what we're going to do is we're going to discuss broad complex regular tachycardia from a slightly different perspective. And without any further ado, let's just jump into the cases that we're going to talk about today. And let's start with case number 1. These are all real cases. This one was a 69-year-old gentleman who presented to the emergency department of Southampton University Hospital, feeling a bit unwell with some chest pain and palpitations. That's been there for a few hours. The patient was vitally stable apart from the heart rate because he was a bit tachycardic, and his ECG showed broad complex regular tachycardia. Let's get you guys to do some work. If you want to scan this QR code, I want you to answer this question for me. You've now faced with a patient who's got broad complex regular tachycardia in his ECG. The patient has got some chest pain and some palpitations. Which of the following comes first in the ALS and ACLS guidelines when it comes to the management of the tachycardia in the algorithm? We're talking about broad complex regular tachycardia. What comes first? Scan the QR code and pick the one you like. Do you want to start with checking drug history, electrolytes? Do you want to check for life-threatening features? Do you want to go for amiodarone? Do you want to treat with a DC cardioversion? Pick the one you like. So it should be working at your end. Some of you have already started answering. And let's see what you think. I'm talking about the first step the algorithm would suggest when you see an ECG with broad complex regular tachycardia in a patient that I have just described to you. So let's see what you guys think. Okay, so the majority of you are going for checking for life-threatening features. Some of you are going for checking the drug history, and no one opted in for any treatment. No one would like to give amiodarone, no one would like to give DC shock. So the majority so far are with check life-threatening features. Okay, great. We'll come back to this, and let's see the ECG of the patient that I've just showed you. So this is the ECG of a patient who presented with palpitations and chest pain. What are you going to do if I ask you, how would you describe this ECG? I think the first thing that will come to your mind when you describe an ECG like this is it represents a broad complex regular tachycardia. You won't get away without mentioning these 3 words. You're going to end up mentioning these 3 words in your head when you look at an ECG like this. And the moment you mention these 3 words, broad complex, regular, tachycardia, you're going to end up thinking ventricular tachycardia. So you're going to end up looking at this algorithm. So this is the latest Research Council UK algorithm. This has been published just about a month ago. So it's a very fresh, I have just reviewed it for the first time today because it's just hot out of the press. So this is the latest guidance algorithm for managing adult with tachyarrhythmias in the UK. So let's focus on the first part of it. It says here that the first thing that you need to do is to assess the ABCD. And once you do this, you check for life-threatening features. So if we follow this algorithm with our patient, the ABCDs didn't really show much. So we moved into the life-threatening features. And then some of you might say, well, this patient is coming with chest pain. And the algorithm here, it clearly said myocardial ischemia is bad. So in this case, we need to go down the shockable side. That's a sign of decompensation. So we'll need to give DC shocks times 3. And if it doesn't work, we need to give amiodarone or procainamide. So this is what this algorithm is going to suggest if you go down the route of this patient is coming with chest pain and a possible VT. So that's the first group of people who might think about the algorithm this way. Some of you might say, no, the algorithm didn't say chest pain. The algorithm clearly said myocardial ischemia. This is very different from chest pain. That pain needs to be cardiac sounding to be considered myocardial ischemia. That means that this patient is stable, which means we need to go down this side of the algorithm. We are now into the broad complex regular tachycardia, that means that we're going to be ending up treating this as a stable VT, which means that we are going to give either procainamide according to the new algorithm or amiodarone according to the new algorithm. So the bottom line is, whether you treat this VT as stable VT or unstable VT, you're going to end up, if you follow this algorithm, giving amiodarone or procainamide. There is no way out of this algorithm without giving these two drugs if you start the algorithm thinking that this is VT. And that is the catch here. Because if you go back to this ECG, you will notice two interesting findings here. The first, look at the complex. The complexes are all broad, but those ones are really broad. They are over 1 big square in width, more than 200 milliseconds in width. This is too much. So that's the first thing that should catch your eye here. And the second thing is the rate. The rate here is 100. A bit slow for VT. By definition, ventricular tachycardia should have a rate that is above 100. But looking at the expert opinion regarding the actual rate for ventricular tachycardia, they've all agreed that the chances of seeing ventricular tachycardia with a rate that is less than 130 is very minimal. So when you see what looks like ventricular tachycardia with a rate that is less than 130, revisit your diagnosis. So when you get these two problems together, really broad complex plus a rate that is not too fast for VT, think about two things as a differential. Think about drugs and think about electrolytes. Those are the two big things that you'll need to consider when you see an ECG like this. In this particular case, this was the potassium of that patient, so it's 7.8. This was a case of hyperkalemia. So I guess some of you might say, so what? The blood is going to come back in an hour and we'll find out that this was hyperkalemia and we'll start the hyperkalemia treatment and then happy days. There is no problem with that. Well, actually, there is a problem. Because if you, during this hour, while you're waiting for the blood to come back to you, you're going to treat this patient as ventricular tachycardia. And now we know that you're going to end up giving this patient either procainamide or amiodarone. Procainamide is a sodium channel blocker, class 1A. Amiodarone is a class 3 antiarrhythmic that works mainly as a potassium channel blocker, but also it's got beta blocking activity, calcium channel blocking activity, and sodium channel blocking activity. Both drugs act as sodium channel blockers. And here is something that I'm not sure if you're aware of or not, but the potassium is toxic to your sodium channels in the heart. Any patient with hyperkalemia is in a state of sodium channel blocking toxicity because of the effect of the potassium. These sodium channels, because of the hyperkalemia, are not acting well. So what happens when you give a patient who's already in a sodium channel blocking state, a sodium channel blocker? If you give procainamide or amiodarone to these patients, that will aggravate the sodium channel blocking effect. This will change this rhythm into VF, cardiac arrest. And this is the problem here. So getting the diagnosis right the first time will be the only cause of survival here. If you don't look at the ECG carefully, if you miss the diagnosis and call it VT, this patient is going to end up dead, and the cause of death in the certificate is going to be your name. So this is the algorithm that we've been following, the latest algorithm from the Resus Council UK, published a month ago. I'm not sure that at the heat of the moment, when you look at this algorithm, you will notice that they said the first thing to do is to check the ABCDE. And one of those things here is to identify and treat reversible causes. And I'm not even sure that if I read this and if you read this, you will think about the potassium here as a treatable cause. So without knowing it, without recognizing it in the ECG, you can end up easily killing this patient. So be careful about this. Amiodarone here is a killer and you shouldn't give it. Procainamide here is a killer and you must not give it. So let's go back to our case. This patient presented to the emergency department with palpitations and chest pain. It's even written by the nurses on the ECG paper that he's got chest pain, and was seen There were concerns about this as broad complex regular tachycardia. The clinician who saw the patient recognized that this ECG is showing a really broad complex tachycardia, and this ECG is showing a rate that is not really going with VT. And one more thing here, look at the QT of this patient. It's massive. If you give amiodarone to this patient, that's another good reason to kill this patient. Just give amiodarone, that will make this worse, and it will end up in a polymorphic VT. So this patient was recognized to have hyperkalemia features rather than VT. Blood gas was done. The hyperkalemia was identified. The patient was treated with calcium, with bicarb, and here we go. So this is the repeat ECG of the same patient, and now it looks like there is a hyperkalemia there, but it looks like more of an ECG like that rather than just this scary looking broad complex tachy that we've seen before. So this is the same patient just after some anti-hyperkalemia measures. And this was our first case. We're going to move on to the second one, and then I can have some of your questions if you have any. Second case is following a similar theme. This time we're going to see again from Southampton Hospital, a 61-year-old gentleman who was found in bed unconscious with a GCS of 3. When he was found by the ambulance crew, he was tachycardic. So the ECG was done, and this was the rhythm strip of this patient. And again, I'd like you to look at this and ask yourself, how would I describe this ECG? Do you really think that there is a way to describe it other than this is a broad complex regular tachycardia? Can you really look at this and get away without mentioning the word VT? It's really hard. I don't think you'll be able to. If you're going down that route, you're going to mention the word VT, and VT is one of those things. Once mentioned, it's really hard to get it out of the equation. So you'll be looking at this and thinking, that is VT. Here is the 12-lead ECG of the same patient. So looking at this ECG, ignoring the fact that the machine is calling it an acute myocardial infarction, the machine interpretation is always there to fool you. Don't look at this. You will notice that the rate here is 129. So this is very close to be a proper VT. So to be honest, the rate is not too slow, but it is still slow enough for VT. But also, the complex is too broad. It's above 1 big square in width. That is not really typical for VT. It can happen, but you will need just to think again before calling it VT. So here is the blood gas of this patient, and the potassium here is normal. So it was not a case of hyperkalemia. The clue in this case was in the clinical presentation itself, GCS of 3. So I know that we've got different levels of experience within the group in here, but those of you who have been practicing emergency medicine for a while, you will appreciate what I'm saying. When you get cardiac patients in ED, they die, GCS 15 looking into your eyes. They're alive, they're dead. There is no in between. If it is a pure C problem, they do not present with a GCS of 3. They do not present with a D problem. In a nutshell, the rhythm that you've just seen cannot make you GCS of 3. You will be fully awake with that rhythm, and then you're going to die. There is no in between. So looking at a patient like this with a GCS of 3 should trigger you to think that there is something else going on. And we know now that we've got normal electrolytes, so we'll be left with looking at the ECG from a different angle, which is the drug side of things. If you look at this ECG, you will notice the following. The ECG is showing tachycardia. The ECG is showing broad complex. The ECG is showing long QT and a very characteristic tall R wave in V1 in AVR. This is very characteristic for TCA overdose. This patient presented with a severe, massive amitriptyline overdose that dropped his GCS to 3 and caused him to have this ECG finding that looked like a TCA, looked like a ventricular tachycardia. So now you know what the problem is going to be. This time you've got a patient who's got presented to you with a sodium channel blocking toxicity, with an overdose of sodium channel blocker. Can you imagine what's going to happen if you give a sodium channel blocker to this patient? How can you justify this to the coroner? If you do that, this patient is going to end up having a VF cardiac arrest. And again, we all know now that the 1A in the death certificate is going to be your name. You are the cause of death here, so don't do this. This is an example from the EM crit by Scott Weingart about a patient that presented with a VT-looking ECG, and actually this was a sodium channel blocker overdose. So sodium channel blocker, they can really present with a confusing ECG that looks like VT, and if you get it wrong, the patient is going to receive the wrong treatment. Here is another example of a patient that presented with a TCA overdose. This is not VT, this is just the TCA overdose. Give these patients the TCA treatment and you will see a different ECG. So let's go back to our patient to find out what happened. The patient presented with this ECG. And again, because of the low GCS, there was a suspicion of a drug overdose. A second look at the ECG revealed all signs of TCA overdose. So he was treated as a TCA overdose and he was given sodium bicarb, and shortly after, the ECG changed to this just by giving sodium bicarb to this patient. Then the patient started to improve, and we found out later that he's taken a massive overdose of a TCA. He was intubated. We've got the collateral history later. He was admitted to ITU, and he survived to discharge. It was a very sad story. He was 64 and tried to kill himself using this, and it was just very sad, but the outcome was a full recovery of this case. So this was our second case, and I'm gonna pause here because I know that you might have some questions, and I'm happy to take any now before we move on to our third case. So any questions from the panel or from the audience?
Yeah, it's been awful quiet in the chat and in the question and answers box, but I think that it's because of the high interest and the nice way you present the cases. So I think that you can present another one, and we'll just sum up if you have anyone questioning anything further.
Okay, let's move on. Hoping that the guys are all GCS 15, they are just interested, and that's why they're silent. Case number 3. I've got a confession to say before starting this case. This case was presented recently by Amal Matu on his ECG Weekly website. And I didn't know this. The case was sent to him, and it was sent to me in the same time by the clinician who saw this patient. So when I saw the ECG, I gave my feedback and opinion about the case to the clinician who sent it to me. And then he told me that Amal Matu discussed it. So I went to his website and I checked it. And I was super proud of myself that my feedback about the ECG was the same as what he did. So I'm just so proud of myself. But I thought I'll have this confession in the beginning. If you've seen this case with Amal Matu, I didn't steal it. It was sent to me rather than anything else. Very interesting case of a 40-year-old gentleman who presented with chest discomfort and shortness of breath and sweating. And again, those of you who've been doing emergency medicine for a while, you know that your patient shouldn't be sweaty in the emergency department. I've never come across a sweaty patient in ED and it turned out to be something benign. There is always something bad about your sweaty patient. It's going to be an MI, it's going to be sepsis, it's going to be a thyroid storm, it's going to be hypoglycemia, it's going to be shock. There will be something bad about your sweaty patient. So if your patient is sweaty and you don't know why, you better sweat. This one was sweaty, short of breath, having chest pain. Vital signs showed blood pressure that's low, heart rate that is high. So he was in shock. The ECG monitor showed a wide complex regular tachycardia. So a 12-lead ECG was done, and this was his 12-lead ECG. And now, I'm going to get you on your phones again with that question. What will be your next immediate action? Would you like to check the potassium and the other electrolytes? Would you like to check the drug history? Would you like to activate the cath lab for PCI? Would you like to give a synchronized DC shock for this shocked patient? Would you like to give amiodarone? Please pick one out of the 5 options. Any more answers? If you turn your phone sideways, the ECG should get bigger, so you can see with more details if that is the barrier here. Okay, we've got some answers here. Let's see if any more would like to. As you see, the answers are anonymized. I'll never know who said what, so feel free just to pick one if you want to.
I already answered. Yeah, good.
Okay, let's see. So some of you, or the majority, well, it's a split decision between a DC cardioversion and checking electrolytes. Fine, I will give you a clue here. Electrolytes and the potassium are all normal. Feel free to change your answer if you want to.
And just to remind me, the GCS was...
So in this one, the GCS was 15.
Oh, nice.
So you've got a shocked patient, chest pain, shortness of breath, GCS 15. This is the ECG. The potassium is normal. Electrolytes are normal. And there is no drug history to worry about. Pick your answer now, please. So it looks like the majority now are moving towards the DC shock, the DC cardioversion. Excellent. Let's talk about the shark fin sign in the ECG, because this is an important one to be aware of. This is a STEMI sign that you must know, because it's not just a STEMI, it's a deadly STEMI that you cannot miss. So this sign has been reported in many case reports. Sometimes they call it the lambda wave, sometimes they call it the giant R wave, sometimes they call it triangular QRS STT wave, whatever. At the end of the day, it's a dangerous sign that you must know, and it is a fusion between the QRS, the ST segment, and the T wave. They all turn into a nice pyramid that looks like a shark fin. It's a high-risk sign, and this ECG pattern can easily be misdiagnosed as ventricular tachycardia or hyperkalemia ECG. Here is an example of the shark fin sign. So this example is a good one to highlight an interesting thing about ECG. The explanation of the shark fin sign is basically you start by getting a bit of an ST elevation. If it gets worse, the elevation is going to be higher. If it gets worse, the elevation is going to be higher. And if it gets worse, the elevation is going to be really high. What you're looking at here is the final stage of this massive elevation. But the clue lies in another fact about ECG interpretation. When you go with any ECG paper horizontally, you are going with time. So this complex happened before this complex, and it happened after this one. So this is the time order of complexes happening in time. Moving horizontally means you are moving in time. When you move vertically within the ECG paper, time stops. So what happens here in lead 3 happens in the same time in lead 2, happens in the same time in lead 1. So when you get an ECG, when you get a complex that looks really broad, let's look at V6 here and look at V5. The complex in V6 looks like a narrow complex with a STEMI. The complex in V5 and V4, just above this narrow complex, looks like a broad complex. That cannot happen because time stops when you go vertically. That means that what you're looking at here is not just the complex in V5. What you're looking at here is a merge between the complex, the ST segment, and the T wave. And the clue is in V6, because in V6 you've got a decent shape complex and then some ST elevation after this. The merge didn't happen in V6, it happened in V5, it happened in V4, that's why they looked like this. But because we moved vertically, we know that what happens in each spot of time happens below it and above it, which means that what's happening in V6 is a true reflection of what's happening within V5 and V4, but we are just missing it. So that's the explanation of the shark fin sign in this ECG. Let's have a look at another example. So again, if you look at the complex, you will notice that in here, if you look at V4, that looks like just broad complex regular tachy. But look at V5. We've got a decent complex with a STEMI. So again, this is the clue here. Look at V6. There is no STEMI in V6. There is no broad complex in V6. As simple as that. Because the STEMI here is confined to one AVL and V1 to V4 or V5. Here is another example of the shark fin sign. So look at lead 1, look at lead AVL, look at lead V4, V5. So these are all shark fin signs. And here's one of my patients. And again, the ECG looks like a beautiful STEMI, except in AVL, this is where the shark fin sign is. So I wanted this pattern to be embedded in your brain before I move on to the case and talk about this ECG. If you look at this ECG, that looks like a broad complex regular tachycardia. You can easily call this ventricular tachycardia. But if you pay some more attention to the details here, you will notice that there is something very odd that is happening here. V3 doesn't match what's above what's below. V3 is showing a narrow complex. But above it, there is a broad complex, and below it is a broad complex. That means that something is not right here. The complexes are not broad. The complexes are narrow, but because of the merge with the ST segment and the T wave, that turned this into a shark fin sign. And then you're going to pay more attention to the details, and you'll notice that actually in here in V5, the complex was narrow, and there is a massive ST depression. In V6, the complex is narrow, with a massive ST depression. So these are reciprocal changes that you're looking at in V5, V4, V5, and V6. So lead 3 is a normal looking complex for this patient. This patient was misdiagnosed as ventricular tachycardia. This patient received 3 shocks as VT, didn't work, so received amiodarone. Cardiac arrest, and unfortunately the patient died. So the outcome of this case was unfortunately not a great outcome, and it was purely because of the misdiagnosis of the ventricular tachycardia, the STEMI, and it was treated as VT. The correct answer should have been straight to the cath lab. This is a STEMI. This is a STEMI with a cardiogenic shock to have the full diagnosis. So, quick learning points, and then happy to take any questions. We've covered 3 cases here. In the first one, we've learned that the potassium is toxic to the sodium channels. So hyperkalemia on its own acts as a sodium channel blocker, blocking toxicity. So if you give a sodium channel blocker to a patient with hyperkalemia, you're simply killing them. So amiodarone is going to be bad in this situation. Hyperkalemia ECGs can mimic VT, and that's a dangerous situation. Then we looked at the TCA overdose, and now we know that TCA overdose can also mimic the ventricular tachycardia, because TCA can make the complex broad, and it can make the complex rhythm tachy. You will end up with a broad complex regular tachycardia just because of the TCA overdose effect. If you treat it as VT, you're in trouble. And lastly, we've looked at a STEMI that looked like VT. This patient was treated as VT, and the outcome was bad. So when the ECG that you're looking at shows what you think is a VT, I would say look at the rate and look at the width. If the rate is below 130, think again. If the complex width is more than one big square, think again. Think about drugs. Think about metabolic. Think about the potassium. Think about sodium channel blockers. And personally, there is no VT patient that I would treat without looking at their blood gas, regardless how unwell they are, unless they're in a cardiac arrest. Let's be realistic. When you face an unwell patient with ventricular tachycardia, you will need to sedate them to give the cardioversion. So you will need to put a cannula. There is some time while you're preparing for your sedation to get a blood gas. It takes 1 minute. Have a quick look at the potassium, make sure that the potassium is okay, and then do whatever you want. Got some references here for you. And lastly, my name is Hesham. I'm one of the ED consultants in the UK. It was a pleasure to be with you here today. If you want a copy from this talk, I've got it via this QR code. So feel free to scan it and get a copy from the presentation. And it will allow me to send you some other useful stuff if you want to. I'm more than happy to be contacted by any of you. That's my email address. That's my LinkedIn account. That's my website. Feel free to find me if you need me. And yeah, happy to answer any questions from you. So that's me done. I'm going to leave you here with a couple of my grandparents and happy to take any questions from now on. Going to stop sharing and I'm all yours.
Great cases. As I was writing in the chat, it's a great case when the majority of the answers turns out putting the patient to the final outcome. Great learning. And we got some questions, and the first one was from my boss, so obviously I need to read it, even if it's got answered, and was about how was the heart rate in the shark fins EKG, and
So
if that is a clue to whether or not it's a shark fin or a VT.
that is a good question. Generally speaking, when it comes to STEMI, patients are really rarely tachycardic. The heart rate in the shark fin one was 115, I think, so it wasn't that tacky. So that's another clue. But generally speaking, you will notice that STEMI patients are rarely tacky unless they're shocked in a cardiogenic shock. Usually, the heart rate of a STEMI patient is going to be within normal or on the brady side because of the vagal stimulation and the involvement of the inferior wall if it is involved. So the heart rate can be a helpful clue here. But generally speaking, the lack of tachycardia is not an exclusion or an inclusion for a STEMI. So I don't want you to think that, oh, fine. So if the patient is tachy, it is not a STEMI. No, it doesn't work like this. So heart rate generally is not that sensitive or specific for anything. This patient was hypotensive, was a bit tachycardic because of the shock and because of the pain. So, but if we're going to analyze it from the VT point of view, that is correct. This rate was below what I would expect from a VT case.
Great. And another question was, if you're present in the primary care and you get this patient and the ECG in front of you, how should you treat it when you aim for the PCA lab, but obviously it's not the very immediate?
Are we talking about which ECG are we talking about? The STEMI or
I think that was about the hyphen as well.
The high potassium?
And no, hyphen. The last case.
The last case.
The shark fin.
Case.
Yeah, sorry, it's my yeah.
No, that's fine.
Fin.
So the shark fin. It is a STEMI. So in the pre-hospital setting, I would basically activate the cath lab via the ambulance crew. I will tell them, because that's I don't know about the system in Sweden, but in the UK, the paramedics they have the power to override and bypass the nearest emergency department to go to the nearest PCI center if they think they've got a STEMI. If they don't think so, they will go to the nearest emergency department. So if I'm a primary care physician and I see this, I will focus on highlighting to the ambulance crew that this is a STEMI, this is not VT, please do not treat as VT, and bypass the nearest emergency department to the nearest cardiac center with PCI. So that'll be my immediate intervention here. And I will give some aspirin.
Yeah. Nice. I think well, there's another question. Do you think that using the adenosine is useful in VTAC in the stable patients if we are in doubt in VTAC?
This is a common question I get, and I have a personal opinion about it. So I guess if we go back to the root cause of this question, the question is, how do we differentiate between ventricular tachycardia and SVT with aberrancy? So it starts like this. This is how I get the question the first time, and then we move on to the adenosine. So to differentiate the two together, my personal view on this is you do not need to, and you shouldn't try to differentiate. And the reason for this is there are so many different ways to differentiate them from each other. So there are Brugada criteria, there are different algorithms. To my knowledge, and please correct me if I'm wrong, none of these algorithms is 100% sensitive. None of these algorithms is 100% specific. That means that they may undercall ventricular tachycardia, so you will be thinking it is not ventricular tachycardia, and it is, and they might overcall them. The danger with this is they will give you the false diagnosis.
Yeah.
And the issue is if you think that this is an SVT and it is actually a VT, then that's bad because you will waste time and it's a life-threatening condition. So that's my first concern about the algorithms. My second concern about the algorithms is none of them, in my opinion, is user-friendly. They are all, there is no chance that you will not need to Google how to do them. And definitely it will take you time and effort to get the ECG and get the algorithm and try to understand what happens. In the heat of a moment, you will be in the resus room, noise, stress, sick patient next to you who is possibly dying. You are not going to have the mental capacity to think. So because of these two reasons, I think there is no point trying to differentiate. If you assume that you're dealing with ventricular tachycardia, you're on the safe side. If it is ventricular tachycardia and the patient is unstable, you're going to shock them. And if it was SVT with aberrancy, the shock will work. So happy days, you've treated both with a shock. If that was VT and you've given amiodarone, it will fix it if the patient is stable. And if the patient was having stable and having SVT with aberrancy, again, amiodarone is going to treat. So treatment for VT will fix both conditions. So that's why I don't really need to think a lot about this differentiation. Then we come to the next level of questions, which is, but what if I am happy to differentiate and I can just give a quick shot of adenosine? If it works, then happy days, it was an SVT and I fixed the patient and I didn't really need to do much. If it doesn't work, I will give amiodarone. So what's the issue with this? And by the way, it's kind of recommended this way in the Resus guidance, in the Resus Council UK. I'm still reading the details in the manual, but it looks like we're heading that way. I have a problem with this as well. There is something called adenosine-sensitive ventricular tachycardia. This is a ventricular tachycardia that responds to adenosine. So let's assume that you decided to do this adenosine test. Let's give adenosine to this patient who's got broad complex regular tachycardia that I'm not sure is it VT or not. Adenosine given, happy days, back to sinus. What are you going to do? You're going to assume that this was an SVT. I do not admit SVT patients. I send them home. I admit all my VT patients. If this was a VT, you are just sending a ventricular tachycardia patient home. assuming it's an SVT. In my opinion, again, this is dangerous. So the bottom line is, I do not use adenosine tests to differentiate the two, and I treat all broad complex regular tachycardia as VT until proven otherwise, provided that I'm not worried about hyperkalemia, and I'm not worried about shark fin sign, and I'm not worried about a drug overdose. If the complex is not too broad and the rate is fast enough, I'm treating as VT. I hope that this answers the question.
Yeah, I'm gonna jump in now. Sorry for everyone. Thank you, cases. It's really now you make me more confused than before, to be honest. But I have a question about the shark fin sign, because sometimes when we get like the ambulance consultation, they're calling us and show us like this type of ECG about the shark fin sign. How do you actually see in this way of perspective? Is it easy to activate the cath lab? Does all the cardiologists or mostly of them knows about it? If there is any like studies about it so we can refer to?
So there is the study that I showed in the presentation, and it is, I think, in my references that I put there. But also the danger is not in this. The danger is, do you receive a 12 lead ECG or a rhythm strip? Because the problem is a rhythm strip can be very misleading here. You need to look at the 12 lead ECG. The moment you see the 12 lead ECG, it's not going to be hard to sell to cardiology. The hard bit is if the ambulance crew just sends you the if they send you the rhythm strip and they're gonna tell you we've got a patient with ventricular tachycardia. This is gonna be the real danger. So I personally didn't have problems selling the shark fin STEMIs to cardiology because I don't really say much. I say I've got a patient with a STEMI. Done. So you don't need to explain yourself much. It is a STEMI. Here is the ECG. The patient is coming your way. But you won't be able to do this unless you have a proper 12-lead ECG. If there are questions, you can explain what we've talked about regarding going vertically and horizontally in the ECG paper and finding narrow complexes under broad complexes and over broad complexes. That means that the broad complexes are not actually broad and there is something wrong here.
Amazing. Thank you very much.
Any more questions?
Yeah, Emery Attis, sorry for my pronunciation, but the question is, your initial ECG showed a sinusoidal pattern. My question is, if we don't have enough experience differentiating this sinusoidal pattern from VTEC and the patient is stable, would it be appropriate to administer treatment after determining potassium levels?
So I don't know about you guys and how long does it take you to get the potassium level, but I do not wait for the lab results. I go for a blood gas, and our blood gas machines, they live in Rhesus, so I get the potassium within a minute.
The same in Sweden.
So by all means, there is no chance that I'll be rushing the treatment without knowing the potassium, because the time that will take me to prepare the amiodarone is actually longer than the time to get a blood gas. So I'll be putting the cannula, I'll send one of the nurses to get the blood gas, and while I'm preparing my treatment plan, the blood gas will arrive. Potassium is fine, done. I'm happy to carry on, assuming that this is not a drug overdose. Potassium is high, I know what I'm dealing with, and I know what to give and what not to give. So I don't really think that this is a matter. So the whole point of what we're doing now is to eliminate the lack of experience bit. You know it now, you've got no excuse. So sorry, but you shouldn't miss this one. There are acceptable things to miss. This miss will cost a life, so it shouldn't happen.
Yeah, and I think that you just proved or showed out the time perspective that it doesn't actually take that long to get the potassium levels. And when you're looking at these algorithms and the boxes, the time doesn't really show, does it? So it seems like you have to choose, but you really don't. You can prepare the treatment and wait for the potassium. So it's very nice. Thank you.
Yeah. So there is a question in the chat about the Research Council UK algorithms. So
yeah, just do you want to read it or should I?
no, I'll go for it. So basically,
Yeah.
I'm just gonna tell you. So the question is basically about the Research Council UK algorithm and where in the algorithm that would add it not to miss cases like this. About 5 years ago, I presented these cases without the STEMI one, the first two in the FRCEM conference, and the title of my talk was "When Following the Guidelines Kill." And the whole idea was, if you blindly follow the ALS algorithm, you will kill these patients. And I used the 2015 guidelines because they were similar. The algorithm was similar in the contents to what we've seen today in terms of the first stage is you just assess the ABCD. But I was criticized because in the 2021 version of it, and they said clearly, well, the first part is ABCD in the algorithm. So actually, you should assess the electrolytes, you should assess the drug history as part of your ABCD assessment. I would disagree with this. In a research situation, I am not sure that I will be thinking in the detailed drug history, and I don't think that this is what's written in the algorithm. So I think you can treat reversible causes the way you like, but we will interpret them differently depending upon how stressed we are and how unwell the patient is. In the 2021 version of the ALS algorithm, they put under the in the box of treat reversible causes, they put e.g. electrolyte disturbance. So I was criticized again that it is there, you just didn't see it. In the newest one, they've removed it. It is not there anymore in the algorithm. So the answer to this question in my head, what I personally do is the ALS algorithm is for the basic management of arrhythmias in my head. But there are situations that I will need to switch from the type 1 thinking, from the autopilot mode, and move into the type 2 thinking and actively think. This is when I start thinking outside the box of the ALS. When I see something that doesn't fit with VT, rate is not that fast, complex is not that narrow, or it is too broad. This is when I start thinking outside the box of the ALS. This is not written in the ALS at all. But again, the ALS should cover the basics, shouldn't cover everything. It's at the end of the day a manual to ensure that we're all up to a certain standard, but we need to get above it. So you need to have an algorithm in your head for the ALS level, and what's outside the ALS, that's a separate algorithm that you need to create for your own. Any other questions? Either from the candidates or from the panel.
No, just want to mention, Hesham, that it's very important, as you said, that the Research Council just provide guidelines, and they are guidelines.
Sorry, Tobias, we don't hear you as well.
Oh, sorry. I don't know. I don't know why it's not working. Can you hear me? No?
It's working now. It's not that clear, but it's working. I can hear you.
Okay, that's good. It's just a great reminder that the ALS and the Research Council provide guidelines, and just guidelines. And you should treat them as guidelines, not as their very distinctive rules that you have to follow. You have to make your own decisions, and you have to make your own algorithms, and they can't put everything in there. It would be impossible to follow. So guidelines
Exactly.
are guidelines. It's a great reminder. Thank you.
Excellent. Thank you so much.
Yeah, thank you, Hisham. That's very interesting cases. I just want to ask you something. If we want to get in depth with our knowledge to increase our competencies in arrhythmias, what do you recommend us?
ECG,
Tips and tricks.
yeah, so I treat ECG, ECG interpretation is a skill. And just like any skill, it's a matter of training. You need just to get your eyes trained. The problem with ECG, I was teaching my junior doctors yesterday, and I said that to them in the teaching session. They are new doctors to the emergency department. So I asked them, how many formal ECG training have you had since med school? And they said 0. Okay. And I'm asking you guys here the same question. How much formal ECG training have you had since med school, assuming that you've had a good ECG training in the med school? 0. The problem is ECG interpretation is one of those things that comes as it's part of the package of a doctor. You're a doctor, you must know how to interpret ECGs. How come that you don't know? And this is dangerous. We underestimate how much we're missing in terms of the ECG education. So I've been teaching ECGs for years now. I've started years ago, and I developed the course because I didn't find the course to help me. So I designed the course that is targeting emergency physicians, so it fulfills the needs of emergency physicians. It's based on emergency medicine cases. All what I found when I wanted to learn about ECGs was cardiology based, and all of it was more of a theory of the ECG rather than I'm a clinician. Give me a patient, give me an ECG, and tell me what to do. As simple as that. So I think this is the right way of treating ECGs and how to train on it. You just need to link it to a story. You will need to get your eyes trained on ECGs and to recognize the different patterns. And the more you interpret, the more you know. But the starting point is to understand that there is a lot that you don't know. And this is dangerous because we don't see our blind spots. And there is a lot of blind spots in our ECG training. There is a lot that we don't know that we don't know. And that is really dangerous. So I would definitely say you need to have a formal training and to treat it as a skill. One more thing. I don't know about the practice in Sweden, but in the UK, I can guarantee that 90% of patients coming to the emergency department will get an ECG and then we'll see what they're coming with. It's the commonest investigation that we do in any emergency department, plus a blood gas. So if it is that common and if we're having this level of exposure, how come that we're not great at it? I said this in presence of cardiologists and they didn't like it. I personally believe that ECG is an ED investigation. It's not a cardiology investigation. And I'm happy to be challenged. How many ECGs a cardiologist will see per day compared to an emergency physician? And what are the varieties that they will see compared to emergency physicians? In emergency medicine, we see undifferentiated ECGs. We don't see the filtered ones. We see the electrolyte disturbance. We see the drug-related changes. We see the raised intracranial pressure ECGs. We see the normal. And it is a diagnosis, by the way. What the cardiologist will see is a filtered ECG with a story. All other non-cardiac causes have been excluded. And bloods are back. And we know what's going on. And we've got a provisional diagnosis. This is very different from you sitting, trying to write your notes, and then a nurse is coming with a piece of paper under your nose to say, sign this ECG for me. It's a patient who came in now with a chest pain, who's going to be waiting for a few hours to be seen. And it is now your responsibility to decide for a patient that you have not seen whether it's okay for them to wait or not. This is dangerous. You need to be trained for that.
Exactly. I totally agree. Yeah. I have another question. Maybe I don't know if there's any questions there in the chat, but like now with the development and the establishment of AI, and there's some medical apps and stuff just helping you. Some of the hospitals, they are using them nowadays. What do you think about them? Is it like a good tool to use in the future or not? As a
Again,
second opinion for us.
I am one of the outliers with this. I am not a big fan. I'm biased. I have to confess first, I haven't really used properly any of the tools there. I know about the Queen of Hearts of Stephen Smith, and the fact that it is coming from Stephen Smith, that's on its own, is a big thing for me. But I have my own concerns about using AI in interpreting ECGs. Many years ago, we used to rely on the machine interpretation of ECGs, and we know that it is rubbish. It gives you, we've just seen that it was talking about the hyperkalemia as a STEMI. So it's just wrong. My problem with the AI interpreting ECGs, even if they're accurate or accurate enough, I've got two problems. My first problem is the moment we trust it, the moment we start being de-skilled, we will not rely on our own skill. If I can get the answer, we're all lazy. If I can get the answer via an app, I will get it via the app. So that's my first concern. I'll be de-skilled. And one day there will be an internet cut. I will not have an access to the AI, and I will have to interpret the ECG, and I will struggle. So that's my first concern. My second concern, the AI will look at the ECG patterns. Never ever assess an ECG in isolation. You'll need to see the patient. You'll need to assess the ECG in the right clinical context. The AI doesn't have this luxury. I have got many stories that I discuss with ECGs that I'm going to show you. You will tell me a diagnosis. I will give you the story. The diagnosis is going to be different. And I do this all the time when I try to teach my junior doctors. So you need to include the clinical context to interpret an ECG. That is not in the AI. They just look at the pattern in the ECG and try to link it to a diagnosis. So that's my second concern. There is a third concern that is a bit fluffy, but I'm going to mention it here. The relationship between emergency medicine as a specialty and cardiology as a specialty is a very unique, sensitive relationship. There is always a little bit of a friction between the two. I've been working on improving this friction in my department for years, and it's now brilliant. When we phone the cardiologists, they listen to us, they trust what we say. I would hate it if it happened one day that I phoned the cardiologist to pass on an ECG to activate the cath lab, and they asked me, what did the AI say about the ECG rather than what do you think? I wouldn't want to see that day. So I'm against. Sorry.
Thank you very much, Hisham. Do you have any more questions? Malin, do you see anything in the questions and answers?
And no, there was a more of a comment from Vishan about how it's been a nice scenario and an acronym tip about DIE. But then another tip for the Swedes about the website ekg.nu that is very helpful indeed. And I think that every resident I met has been in knowledge of that website. So I think it's pretty well spread. But I don't think that it actually is as good for the thinking of and the acting in when you get the ECGs in front of you and the patients. It's more about the ECG in my experience. So I think that this webinar and I suppose also your course looking forward to is a very good part in developing the knowledge as well. Sorry, I'm so tired. My words stumbling up.
Sure. Thank you very much. Yeah, we have one of the audience who raised the hand. Sophie, I think it's okay if she can speak, but let me try my skills. Yes, Sophie, the mic is yours. You can speak.
Can you hear me now?
Yeah, sure.
Oh, perfect. I just want to thank you as well as thank the rest of us for a really good, I was going to say session, but there you go. I think a point of it as well is because it's such a skill to interpretate the ECG. And I mean, as any skills, you have to be interested. Something we're really interested in, that means we can get really good at it. So with this, I just hope more people also have the interest and have the respect that not stress each other to interpretate it. So we can take the time, if we're not, a cardiologist, excuse my English there, I think we should respect each other that it is a skill and not rush it to sign it for it. So that's, yeah. And I hope we're going to all get better now to understand the importance of them. So thank you for this time.
Thank you.
Thank you, Hesham. I'm really surprised because when we spoke about the sessions and about the webinar, we thought that we're going to speak about the usual, the VTAC, but now you let me actually to think really out of the box. It's not just keeping in mind everything wide complex tachycardia as a VTAC. We need to think out of the box, which is really appreciated.
Thank you so much. I just felt that I'll try to aim for something that is not commonly talked about, and I always okay, that's another confession here, and that is particularly for Sophie because she's mentioned that we need to be interested in learning ECGs. Over the years, I've trained many. Trust me, the way to learn a skill is to be scared of missing something, to identify the weaknesses, to get you to face your weakness and to create that kind of fear inside you will be the drive to learn more. This is what worked for me. We all don't want to miss life-threatening problems. But again, the problem is we don't know what we don't know. All what I'm trying to say here and to highlight that there is, by the way, a lot that we don't know, and it can cause patients to come to harm. And this is what we're trying to avoid in here. The fact that, and I get that from my junior doctors all the time, I ask them before we start the session, are you okay with ECGs? And they always say, we're okay. I mean, we're gonna spot the badness and feel that something is wrong, and but not probably the tiny bits. This is dangerous. You think you will spot the badness. You don't know that you're gonna miss it. There is a lot of badness that you need to know to be able to spot it. The rule is you'll never see what you don't know. You need to know it first, then you'll start seeing it. So the fact that from tomorrow morning you will start seeing shark fin signs, it is not an outbreak. This is just your eyes seeing things that didn't know that they do exist before. Now your differential is broader. Not every broad complex tachycardia is VT anymore. You know when to treat as VT, when to treat as something else.
Amazing. Thank you very much. I think we are running out the time now. I just want to flag for the audience about your both courses or the website that you have from Zero to Hero and the EPEC 1D course if they want. So maybe you can send us the link so we can send it to my colleagues and the other.
I can put it now in the chat section if anyone would like to have a look.
Amazing.
Be my guest.
Thank you very much, Hesham, for having you with us. And we absolutely want you again to speak about more interesting stuff in the future. Thank you for our moderators as well, Malin and Tobias, and thank you for the audience as well. I just want you to keep you in mind, like on the 14th of January, so we will host a new guest, which is Sheldon Sheskas. If you know him, he's the medical chief from Sunnybrook Hospital, with our well-known Swedish emergency physician Therese Järv. They're going to speak about the dual sequential defibrillation. So it will be amazing. Keep it in mind. Okay, thank you, everyone. Wish you for having you and us tonight. Bye-bye. Take care.
Thanks for having me. Cheers.